So if you treat these patients conventionally plus this approach, you have better results and more durable results.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar, I am feeling pretty international in my thought process. You know, we've just been so focused on how we do things here, but I think, dermatology is way bigger than just us, and especially integrative dermatology. What do you think?
Oh, yeah, for sure. I think that the field of integrative dermatology is growing. I mean, we are getting inundated with interest in every aspect of our work, right? And it is not surprising that when you look outside of the United States, you find other experts who bring their own take on integrative dermatology and their own practices and attitudes. And a lot of integrative medicine is driven from cultural changes. So it's always good to keep an eye open kind of across the pond and see what's happening in Europe and Africa and the Middle East and other areas where we know there are strong cultural drives and that can drive folk medicine that translates into integrative approaches. But also excellent regular dermatology, great medicine as well. And so seeing how clinicians integrate both of these is really cool. And we can learn a lot from that, right?
Absolutely. In fact, we look to a lot of the Eastern medicine as, being a source of viewpoints that go in kind of in what we'd say integrative fashion with conventional medicine. But
Right.
I have to say our European colleagues were probably multiple steps ahead of us. I mean, you look at Germany, you look at France, and you look at a lot of the leading researchers out there, and we are so lucky that we have one of them here with us today. They've kind of led the way for integrative dermatology. And frankly, they were doing this way before we've been doing it here in the United States.
Absolutely. And I think today we have one of our pioneers in integrative dermatology all the way from across the pond. Do you want to introduce him?
Yes, all the way from across the pond in France. We have Dr. Philippe Humbert. He is a professor of dermatology. He's now retired, but he has done a tremendous amount of work, and he was at the University Hospital of Besançon. I may have messed that up, Dr. Humbert. Please correct me if I did, but I also want to say that he has been super prolific. He has published over 600 international papers, and he has honors that include the Knight of Academic Palms and multiple awards from French dermatological and cosmetology societies. Philippe, we are so excited to have you join us on the podcast. Thank you for being here.
Thank you very much, Raja. Thank you.
And please correct me on my pronunciation. Which university were you at? Because my French is definitely not up to par.
Yes, it is a little university at the east of France. The name of the city is Besançon.
Got it. It sounds so much more elegant when you say it.
Yeah, Raja, good luck. I think we're going to let Philippe pronounce those because it sounds a lot better. Philippe, welcome to the program. You have trained as a medical dermatologist and really practiced that, but at some point you figured, hey, there's maybe something more out there. So what led you to incorporate integrative medicine into your dermatology practice?
Oh, I learned internal medicine, so I became a specialist in internal medicine, as well in the disease of glands, endocrinology. At that time, it was possible to have 2 or 3 specializations. And step by step, I became a radiologist, and also I took care of skin cancers. So I have a large overview of medicine, which has been very helpful for me to see dermatological patients.
I think that's fantastic. And, you've done so much work in really helping us understand that it's not just the skin, but it's much deeper than that. So can you give us a little bit of an idea of where you form these impressions. Is your impression that most of the underlying pathologies in dermatology, do they come from gut health and the gut?
Oh, yes, I would like to tell you that I observed that for every patient, the dermatologist has the same protocol. For example, the dermatologist sees a man with eczema, the treatment will be steroids. The patients have acne, the treatment will be benzoyl peroxide. I thought to myself, if this is what medicine is all about, I'm going to get bored writing the same prescriptions all day long. For example, a young female patient told me that since the time she has been having disturbed periods, namely period that come every 2 months, spaniomenorrhea, as you know, that the periods last 7 to 8 days, menorrhagias, and that they are painful, premenstrual syndrome, her acne has become worse. I realized that she has what gynecology have taught me, premenstrual syndromes with polycystic ovaries. So I said to myself that if I wanted to improve her acne, I'd have to treat her gynecological problems. That is very simple for this example, but we will see more difficult problem. And then, by chance, this child with eczema that I had previously treated with betamethasone, as everybody, spontaneously significantly improved when his mother took her on vacation to her country of origin and starting giving her child goat milk. And little by little, I realized that there were indeed internal causes for all these skin condition. And I had my first integrative medicine successes with atopic dermatitis and acne. And as you just said, yes, gut may be the main target or the main root of the majority of diseases. In fact, from what I have read and from my own observations, 80% of skin disorders stem from an intestinal abnormality. I don't know if you agree with that, but for example, I learned that women, and that is very exciting to see that, women who had cystitis, for me, urinary infections, urinary tract infections, and so-called mycosis, actually had intestinal parasites. I am not sure that every doctor knows that. When a female patient told me that she had had a dozen occurrences of urinary infections, I asked her to show me her urine lab analysis. I was surprised to see that her lab results didn't meet the classical criteria for a urinary infection. Either there were no bacteria or there were white blood cells, but in very insufficient numbers. So I suggest that every doctor looked at these results when a female asked for urinary infections. And when the female patient talked about mycosis, she wanted to say pruritus, and the mucosa didn't appear red with white deposit. That is not a candidosis. And if samples are made, we don't find candidosis, or if we find candidosis, it could be normal because half of women have candidosis in that area. In fact, there was only mucus and phlegm, but no so-called vulvar candidiasis. So I thought it was a misuse of language to talk about mycosis when the vulva itches and secretes mucus. At the same time, I discovered that these female patients also had an itchy anus. So I conceived that this could be manifestations linked to the presence of parasites, that is small worms in the intestine. And I could say that this observation is one of the most important in my life of doctor, because as soon as you discover such parasites, you be sure that people have an intestinal disease. And then my readings, my experience, and the healings of these so-called urinary problems after antiparasitic treatments convinced me that parasites were what it was all about. And do you know that parasites decrease immunity and they allow papillomavirus to increase? And some doctors, when you have a cancer of the cervix of uterus due to papillomavirus, they first begin to treat the worms. That is exactly the case for herpes. People suffering from herpes may have parasites in the gut. That is the same for COVID. And you have seen that some drugs for COVID are antiparasite drugs. So, which kind of disease we have behind the parasitosis? That is the main question. And these questions is the basis of my reflection.
You know, this is pretty fascinating to think about, because what you're saying is that you've been thinking about gut health. I know you mentioned parasites here, but I did want to ask you about some other things that you've also been looking at. I really want to appreciate the fact that you didn't settle for just benzoyl peroxide for all acne. Thank you. That would have been very boring. That would have been not enough treatment options. But the fact that, you started thinking about the gut, and now you also have expanded from parasites to think about things like the role of gluten or cow's milk.
Yes.
And while this is not classic in dermatology, can you talk a little bit more about, the role that gluten has, or maybe cow's milk has? And I think a lot of people will ask, isn't that going too far outside of dermatology? Back then, you must have had all those kind of questions.
Yes, in 2006, I published a paper on the skin diseases related to gluten. It was not so known at that time. And only 10 years later, the description was made by Dr. Lebwohl 5 years after the new gluten in the market with double concentration of gluten. And it is very interesting to take care on this gluten because it modifies the intestinal barrier and it is able to provide Parkinson's disease, multiple sclerosis, psoriasis, and so on. And if you look at PubMed, you will see that there are proofs of the good effects of gluten withdrawal in order to treat psoriasis, diabetes, multiple sclerosis, and other diseases. So that's very amazing that we have under our eyes the main product which is involved in so many diseases. The problem is, for example, for the worms, the problem is if you search for them, you don't find them. If you look for worms into the stools, they are not into the stools. If they are in the stools, that is normal. But if they are not on the stools, they are sticked on the mucosa very far from the anus. So you don't see them. How can I make the diagnosis of worms? Just looking at the previous blood samples. And you will see 5 years ago or 20 years ago, high number of eosinophils. And these blood cells, which increase sometimes, like the Lavier curve. I don't know if you know this name in America, curve of Lavier, that is important to be sure that the people have worms. And for gluten, there is no biological samples to be sure that you are gluten intolerant, because we know the antibodies against transglutaminase, against gliadin, against endomysium. But these antibodies are present in celiac disease, but not in the new disease, which is non-celiac gluten sensitivity or non-celiac gluten intolerance, described by Mr. Lepvol in 2015. At that moment, we have only 500 publications on this syndrome, but there are so many descriptions that you cannot fall into holes and you are sure to know this disease. You must know this disease. It is so important. And I have discovered also, because it's very helpful, the cutaneous signs of this gluten intolerance. You know what is pilar keratosis. It's very common, but that is the main expression of gluten intolerance. And to be sure that people have gluten intolerance, look at different parameters. For example, immunoglobulins A. Sometimes they are high globally, sometimes they are low. You may look at neutrophils, for example. You may look at other autoimmune diseases which are associated with. For example, Hashimoto's thyroiditis is associated in 1/3 of gluten intolerance. So by these mechanisms, you can be sure that patients have gluten intolerance. And if you stop gluten, maybe you have good results, maybe not. Why maybe not, even if you are sure patient is gluten intolerant? Because if you have 4 holes in a tube, if you block only one, you will not have any results. If you block 2, it could be milk and gluten, because milk is also involved in gluten intolerance. Milk of cow, not the milk of other animals. And there are some reasons. But if you withdraw gluten and milk, you will have in 80% good results. But if you treat the worms, because at that time you have worms, if you treat the deficiencies, then you block every 4 holes and then you cure the patient. So there are many reasons for knowing and having gluten intolerance.
That was excellent overview, looking at the 4 horses as you phrase it, and trying to modulate the response. Even if you don't have an exact response, I think a lot of times we tend to think of, oh, we have to do this and that, and everything has to be evidence-based. Sometimes if the intervention is done correctly and it's safe, like withdraw gluten for a certain amount of time, something you can do safely and has very little side effects, and you can see if you get good response, as you mentioned. I wanted to move forward and see if you can explain to us how hyperlaxity is correlated with intestinal pathology and gluten, and perhaps explain what's hyperlaxity first, and then how it's correlated with intestinal pathology and gluten.
Okay, I am very proud of that, because in 2006, I made this research with a student, Lauriane Louvrier, and she made her thesis on this research. We looked at people having either Ehlers-Danlos syndrome with very high laxicity, or just normal people with hyperlaxicity. What is this? They are, most of the times, they have a problem with the articles, so fragile articles. And they are able to fold the hand onto the forearms and to nearly touch the forearm with the thumb. So that is how I evaluate laxicity. And when you have laxicity, you have lucky gut. Why? I suppose that the conjunctive tissue supporting intestine is so fragile that the big molecules of the milk, casein, lactoglobulin, lactalbumin, plus maybe pesticides, maybe growth factors, maybe antibiotics you have in the milk. All this mixture is able to endure intestine supported by such a fragile conjunctive tissue. And that is the case when you are young. And how can you be sure that the patient is intolerant to milk? He has had throat and nose infections when he was very young. And most of the time, these people have been operated for the amygdals or the big nodules in deeper in the throat. So when you have that, you be sure that you are milk intolerant. It has been demonstrated by Dr. Rancé in France in Toulouse. This fragility of the intestine due to the conjunctive tissue is also disturbed by the gluten in 2010, and gluten, double concentration of gluten with pesticides also induces injuries of the intestine mucosa. It's why 5 years later, Mr. Lebwohl described for the first time this new disease, non-celiac gluten intolerance. That is a relationship of laxicity and leaky gut. And what I demonstrated in 2006 was confirmed by two studies, Israeli one and Swedish one, in children and adolescents, but in adults, that is exactly the same.
That's great. Thank you, Philippe. Always interesting how our physical exam can really tell us so much more about the patient than we originally think, right? So,
And Hadar, can I jump in with a question here? How do you test for hyperlaxicity? How do you do the exam in the clinic? Is that something that you test on most patients?
Oh, yes, it's very, very simple. You take the hand of the patient and you fold it and you see how he is able to touch the forearm with the thumb. And most of these people have had problem with articles. Maybe Barbara can help me. That is entorse of la cheville, par exemple. I don't know what the good word for that.
This is so interesting. I think everybody listening is going to be trying to see if we can, and I know I'm doing it right now. Can I stick my thumb to my forearm? Should I be worried about something there? I'm sure.
Yes, and many people are lax, but it's not sufficient enough. If you don't have any gut problem, if you don't have edema or pain or diarrhea or constipation, you don't care of the laxicity. But if you have these gut problems, it is very important to look at it.
Okay, so I think what you're saying is that this is interesting because you're talking about all of these different approaches to understanding our gut health, and you're effectively saying that in some cases, if you can eliminate gluten, you can improve these diseases. Is that what you're saying? That if you can cut gluten out, that can be helpful?
Oh, yes, when you have patients with acne or psoriasis, you take care of these diseases as usually. But if you demonstrate these intolerance, which are very frequent, milk for acne intolerance is very frequent. There are many publications of that. Milk absorption aggravates acne. Milk avoidance improve acne. That is the same for gluten and psoriasis. So if you treat these patients conventionally plus this approach, you have better results and more durable results. And if you take care of something else, when you have such a gut disease, you may have insulin resistance, which is very frequent with such gut diseases. So insulin resistance is something very severe because it is the first cause of stroke, of infarcts, of cancers. So you look for insulin resistance, you may treat it, and that is one more important way to cure the patient.
Yeah, I think this is pretty interesting because, I love that you're talking about elimination. You've probably been doing this for a while, just talking about how the diet and certain foods can impact dermatological diseases. And absolutely, you've probably been saying this for many years. I think the research literature has now also caught up to this because I think a lot of people understand the link between, especially milk and acne, for example, as you point out. And that leads me to my next question, which is, you've got this idea that, reducing gluten may be helpful in certain scenarios, or whether it's reducing milk or reducing gluten. It's not always easy for people to do that historically, although now I think there's a lot more gluten-free options. But how can you be sure that someone is gluten intolerant? And then how do you advise them to reduce those foods?
Yes, that is a very good question. First, the evidence is not for all the life. It's just a 1 year duration because during this year, the gut is getting better and it cures. And when it is cured, you can eat again with small quantities milk and gluten. So you explain the patient that it's not all his life. Moreover, this regimen doesn't aggravate the weight loss. That is the contrary. When you stop the food which aggravates the gut, people have increase of weight or they stay stable. But this regimen doesn't lead to deficiencies. That is the contrary. This regimen corrects the deficiencies. So it's not so difficult. I explain with few words. You stop the cookies, okay, the pizzas, the bread, and you change for another bread with another component. For the milk, you stop milk, cheese, yogurt, cream, and butter. And you take the green or yellow boxes with vegetable butter. You take the cheese of other milk animals, animal milks, and so on. So it's not so difficult. That is not a problem of very few quantities. That is a problem of normal quantity. So it is completely different than a celiac disease. So it's not difficult to convince people to make this because in 2 weeks, 3 weeks, they are so improved that they call you and they said, doctors, I couldn't imagine how it was possible to cure so fast with so easy regimen.
And, I think that pretty much sums up what you're saying.
Yes.
In integrative medicine, this is the whole approach. You really are a pioneer to take these approaches. I'm sure that you faced your own challenges with colleagues that might have said, what's the science and whatnot. But boy, were you leading the way. We really appreciate that. And I think that, was there any comments that you wanted to make too, Hadar? Because this is such a really interesting topic.
Yeah, no, I think it's really fascinating. And I know counseling patients on diet is always challenging. So your question, Raja, was really apt. I think that every time we talk about cutting beer and pizza, most of my patients are zone out a little bit, but definitely nowadays we have better solution, let alone butter, right? How do you cook in France without butter? I don't know how you do that, but it's definitely now a new time where we have a lot of different options. And I think your clinical observation that when people improve, they're finding new motivation to really be compliant with the diet and giving them sort of a light at the end of the tunnel saying, hey, it's only for a limited time. It's only for a year.
Yeah.
And then slowly you can train your gut. I think all these are excellent, excellent tips for clinicians who are trying to adopt this into their clinic. So thank you for that.
Thank you.
And then I just want to really appreciate you joining us all the way from France. Although we've gotten very close thanks to electronic technology and the internet, nevertheless, we appreciate you joining and giving us some of your expertise, some of your thoughts, and really some of these pioneering thoughts that kind of was probably the groundwork for integrative dermatology. And so we appreciate you for that too. So thank you so much.
And thank you also for your kind invitation in Dallas. Thank you.
Yes. So what you're referring to is the Integrative Dermatology Symposium. So for all of you that are listening, you missed out on a fantastic lecture that just occurred at our recent Integrative Dermatology Symposium. But for all of you listening, you can join us at the next one. Our next upcoming one's going to be in August in Tucson, Arizona, 2025. Check us out on learnskin.com or Integrative Dermatology Symposium. Easy Google search. With that, I just want to, again, thank you again, and this was fun.
Thank you so much to everybody.
Folks, we'd like to invite you to check out our colleagues in the dermatology podcast family, Dermosphere.
Luke and Michelle are two board-certified dermatologists who also discuss the latest research in the world of clinical dermatology. Learn about recent drug trials, disease pathogenesis, off-label drug treatments, and more.
Come for the dermatology, stay for the dad jokes. Dermosphere has been around since 2019, and I just love seeing how they grow as part of our podcast community. Search Dermosphere wherever you find your podcasts.